invite Dr. Sanjeev Phatak. He is also a well-known diabetologist, and there is no need of introduction, but my role is for introduction. So he is a distinguished clinician practitioner in the field of diabetes and metabolism in the Ahmedabad since 1991. He is Clinician Director of Diabetes and Metabolic Medicine at Maringo since Ahmedabad.
Thank you very much, sir. You can just skip it because my intro will look minuscule compared to what Dr. Bansi has. And there are so many big dignitaries sitting here, Dr. Paribal Bhai, Dr. Mehul Bhai, Dr. Pragnesh Vachrajani, and I can see now young and mixed crowd here, still either waiting for lunch or after having finished their lunch and they have come here. So it's really a pleasure and honor to be addressing the Ahmedabad Medical Association audience, and I'm really very thankful to the office bearers. So what I will be running through, Dr. Bansi took you through the journey of the Mounjaro, that is Tirzapatide, and its effect on type 2 diabetes, and the trials were SURPASS trials. I will be talking about its role in obesity in people without diabetes. So this is my disclaimer. This is a Lilly supported symposium, so I am representing on behalf of that, but the opinion will be absolutely unbiased. I'll make sure about that. Dr. Bansi talked about the physiology of Tirzapatide or the GIP GLP. He very well threw the highlights on the, can I use the pointer from here? Yes. He talked about the GLP activity, reducing the food intake, increasing the satiety on insulin secretion. It has good effect. It reduces the glucagon secretion, and the GIP component, which is very new, though it was discovered earlier, it also reduces food intake, but it decreases nausea compared to increased nausea with the GLP. So if you combine these two, the nausea should go down. Moreover, it also has effect on insulin. It increases the insulin secretion, and for glucagon, there is a very peculiar effect. When the blood glucose is high, the glucagon secretion will be low. When the blood glucose is low, the GIP will work to prevent hypoglycemia by increasing glucagon secretion. So that is unique about the GIP activity. At adipose tissue, these are some beneficial effects, but endogenous GIP in absence of GLP will actually have negative activity on fat. It will synthesize fat, it will store the fat, whereas GIP when combined with GLP-1 activity, it improves the lipid buffering capacity, increases the blood flow into the adipose tissue, increases the storage capacity, and has anti-inflammatory effect, which is one of the effect through which this drug has been shown to reduce the cardiovascular event rates. Of course, at present, it's not an indicated drug for that. So GIP is a nutrient stimulated hormone, so many effects. Dr. Bansi already talked about that. So I'll just run through some of the important clinical trials that have been in the development program of Tirzapatide. But before that, we should remember these two DCGI approved indication of this drug. Type 2 diabetes. Type 2 diabetes, you can give as monotherapy when metformin is inappropriate or not tolerated or contraindicated. Or in addition to the other medicinal products like metformin you are using and not controlled, you can still use Mounjaro as a second drug. Second is, even in people without diabetes, if the person is overweight or obese, for chronic weight management, it can be used. It can be used if the BMI is more than 27 and if the person has one additional comorbidity in addition to obesity. That means either type 2 diabetes or hypertension or obstructive sleep apnea or cardiovascular disease like that. So 27 થી વધારે BMI હોય, સાથે એક comorbidity હોય, you can use. Or else, if the obesity is significant, that is more than 30, without even any comorbidity, one can use Mounjaro. So these are the approved indications of Mounjaro. Type 2 diabetes, any level of BMI, even 24, you can use. About 27 for obesity you can use if patient has diabetes, but more than 30 you can definitely use even in absence of a comorbidity. So this is the trial program, the Surmount 1, Surmount 2, Surmount, Bansi talked about Surpass trial, which is in the patients with diabetes, and Surmount trials are in patients with obesity for weight reduction, where Surmount 1 is weight management trial in patients without diabetes. Surmount 2 is weight management trial in patients with diabetes, with weight being their primary target. In other trials of diabetes, HbA1c is the primary target. And we'll talk about Surmount 5. We'll not talk about 3 and 4 because of want of time, but Surmount 5 is an important trial comparing it with semaglutide. Just a brief overview of Surmount 1, 2022. It was published in NEJM. The trial was comparison of Tirzapatide 5 mg, 10 mg and 15 mg versus placebo in people with obesity or obesity with complications without diabetes. 26,100 plus patients, and you can see the results. Placebo just 2.4 kg weight, 2.4% weight loss, minimal weight loss, not significant. Of course, placebo group also had a good diet and lifestyle intervention. The other groups were Mounjaro 5 mg, 10 mg, 15 mg. Mounjaro 5 mg, 16% weight loss. Mounjaro 10 mg, 21.4%, and Mounjaro 15 mg, 22.5%, which means that a person of 100 kg will become 78 kg within a period of 72 weeks. And you can see most of the weight loss is within first 36 weeks, like 6 mahina much. So within 6 months, whether you are taking 5 mg, 10 mg or 15 mg, you will have a really meaningful weight loss. And as Bansi said, more than 10% weight loss can definitely improve your metabolic profile significantly. 15% weight loss can cause diabetes reversal or remission, and it is associated with significant reduction in the cardiovascular risk. So such a robust data, 16% average reduction with just 5 mg of Mounjaro, which is the minimum dose. Starting dose is 2.5. You up titrate compulsory to 5 mg, and 5 mg can cause 16% weight loss, whereas 22% weight loss with 15 mg. So huge weight loss. The next question is, how many percent of your patient will have weight loss? Patient will ask you, "Sir, maru vajan ghate ke nahi?" The chances are that 90% or even 95% will have more than 5% weight loss, which is the weight loss required for obesity indication globally. About 75 to 90% will have more than 10% weight loss depending upon the dose. About 50 to 75% will have more than 15% weight loss. And you can see more than 20% weight loss, जो 5 मिलीग्राम लेता हो तो 31% में 1 in 3, 10 मिलीग्राम लेता हो तो 1 in 2, અને 15 મિલીગ્રામ લેતા હો તો almost 62%, which means the probability of having good weight loss is very, very high if you are put on Mounjaro. So even the lowest maintenance dose of Tirzapatide 5 milligram had 1/3 of the participants losing more than 20% of their weight, which is again mammoth. વેટ લોસ થાય એટલે નેક્સ્ટ પ્રશ્ન એ આવે, સાહેબ મસલ નહીં લચકી પડે ને, મસલ નહીં ઉતરી જાય ને? ઓફકોર્સ દેટ ઇઝ અ રિયલ કન્સર્ન એન્ડ દેટ કેન હેપન ઇફ ઇટ ઇઝ નોટ કપલ્ડ વિથ ગુડ પ્રોટીન ડાયટ એન્ડ ગુડ અમાઉન્ટ ઓફ એક્સરસાઇઝ. બટ ધ ગુડ પાર્ટ ઓફ ધીસ મોલેક્યુલ ઇઝ દેટ most of the weight that is lost is from the fat and not from the muscles. Of course, when you lose weight, it is likely that you will lose some muscles also if you are not exercising or not having protein. But most of the weight loss, almost 75% of the weight loss comes from the muscles, from the fat rather, and rest of the weight loss comes from the muscles. Amongst the muscle loss also, most of that is intramyocytic fat loss, and that has been seen in most of the studies. These are DEXA supported studies, so a lot of fat is lost, especially the visceral fat. So that makes this drug one of the most favorite agents, and that's why the drug has been sought about by the patients rather than prescribed by us. It's not just weight loss. There is additional benefit. Systolic blood pressure goes down by 7 to 8 millimeter, diastolic 4 to 5 millimeter, triglyceride goes down, HDL comes up, LDL goes down. So these are additional benefits which can get translated into cardiovascular benefits later on. This was SURMOUNT-1 trial comparing different doses of Mounjaro versus placebo. SURMOUNT-2 is in type 2 diabetic patients. Those were the patients without diabetes. Now these are the patients with type 2 diabetes. What happens to their weight? And the trial has comparative arms of placebo, 10 milligram and 15 milligram. And you can see the weight loss. Placebo, hardly 3.3% weight loss. 10 milligram Mounjaro, 13% weight loss. 15 milligram Mounjaro, 15% weight loss. Can you notice this weight loss is less than what I showed you in the non-diabetic people, and this has been seen across the board, across the molecules, that diabetic patients lose less weight compared to non-diabetic. Several reasons have been implicated, but still final verdict is not out whether diabetic people, they are having more insulin resistance, they are having some other drugs going on like pioglitazone or insulin, and that is making them less efficacious as far as the weight loss is concerned. Nobody actually knows the reason, but this observation has been there in most of the trials that diabetics lose less weight compared to the non-diabetic people. Again, as far as the weight loss percentage is concerned, more than 5% weight loss in about 80 to 90%, more than 10% in about 70%, more than 15% in about 51%, and more than 20% in about 34%, which means most of the patients will have 10 to 15% weight loss with Mounjaro, even if they are diabetic. The HbA1c also comes down, which was not the primary target in this is a secondary target. Baseline HbA1c 8. It came down to 7.82 in the placebo group, and it came down to 5.7 or 5.8 in the Mounjaro 10 and 15 milligram. Less than 6.5 without drug is called reversal. You can see the almost reversal or remission effect, of course, when the patient continues Mounjaro. So a significant reduction in the HbA1c and a significant weight reduction in type 2 diabetic patients. Finally, coming on to the SURMOUNT-5 trial, and this is a very interesting trial. In the current world, no two drugs will be compared by a sponsor, because you will always be afraid if the other company's drug defeats our drug, what will happen to our drug. But Lilly people, they did the comparison of their Mounjaro with semaglutide, which is Ozempic. One group was given Ozempic, the other group was given Mounjaro. What was the dose? The dose was of Ozempic 0.25 to start with, then 0.5, then 1, then 1.7. And if patient can tolerate 2.4, that is the maximum dose, 2.4. So either 1.7 or 2.4, that is the maximum tolerated dose of Ozempic in this trial. And Mounjaro 2.5, 5, 7.5, and then maximum tolerated dose of 10 or 15 milligram. So a great comparison of maximum dose of Mounjaro versus maximum dose of Ozempic. And you can see what happened. This is again a trial in people without diabetes. You can see 21.6% weight loss in the Tirzapatide or Mounjaro group compared to 15% in the Ozempic group, which means that both the drugs caused good amount of weight loss, but weight loss was significantly more, 21% in the Mounjaro group compared to the Ozempic group at the end of 72 weeks. And again, if you look at 6 months, most of the patients would have lost about 17-18% in the Mounjaro group, whereas 12% in Ozempic group. More number of patients again lost weight in the Mounjaro group. Again, you can see that more than 10% weight loss, 90% versus 67%. 15%, 71%, 46%. 20% weight loss, 54% versus 31.9. and more than 25% weight loss in 36% of the Mounjaro patients versus 19.4% of the semaglutide patients. Again, meaning thereby that the weight loss potential is much more with tirzapatide compared to semaglutide across the spectrum, and the number of patients or the number of participants who would lose weight is also higher in the Mounjaro compared to semaglutide. Interestingly, not only weight, but the waist circumference also goes down very significantly. 20 centimeter down, એટલે 8 inch, 40 થી કમર 32 થી થઈ જાય. Huge impact. Whereas with semaglutide, 14.7, એટલે લગભગ 6 inch જેટલી ઘટે. 8 inch versus 6 inch, again a significant difference in the waist circumference. So no need to tell, no brainer that the efficacy of tirzapatide is humongous. Great effect on weight, great effect on HbA1c, and better effect compared to semaglutide. Now what about its adverse effects? Are they more compared to semaglutide? So these are the tirzapatide trials. The most expected side effects are gastrointestinal. We all know about that. That is how it works. Once you also told that it is one of the effect and not a side effect. If you try to over it, you will have more nausea. Some side effects like constipation, diarrhea are peculiar again, but can be mitigated with proper lifestyle, fibers, and sometimes some natural or minimally effective drugs. Interestingly, in the SURMOUNT-5 trial, which was comparison against semaglutide, the side effects, in spite of having more efficacy, were not more in the Mounjaro group. Very importantly, if you see nausea, constipation, diarrhea, almost similar. Vomiting, 21.3% with semaglutide versus 15% with tirzapatide, probably due to that GIP component which reduces nausea and vomiting. And in clinical practice also we have seen that Mounjaro is better tolerated than semaglutide. Individual differences may be there, but by and large. The other side effects are actually not remarkable. The only other side effect apart from the gastrointestinal side effect we see is hair loss, again probably because of some nutritional deficiency due to less food, maybe iron, maybe calcium, maybe magnesium. You can easily supplement them and prevent that. The serious side effects leading to discontinuation can happen, but in about 7-8% patients, not more, if you counsel the patient properly and mitigate the side effects that are expected. So to summarize, tirzapatide, you can see, causes significant body weight reduction, more so in the non-diabetic people, but also in the diabetic people. 16% with 5 milligram, 22.5% with 15 milligrams. So even minimal dose is also very, very efficacious. It demonstrated superior weight reduction compared to semaglutide, 21.6 versus 15.4. It also improves the key cardiometabolic parameters, blood pressure, waist circumference, that is central obesity, triglycerides, HDL, also LDL. And the most common adverse effects are expected, that is gastrointestinal in nature, mostly mild and usually transient, not long term. If patient continues for 6 months, by that time most of the side effects would have gone. Long term side effects still are under investigation, but not seen in the robust trial program of more than 10 years now. So to conclude, tirzapatide demonstrates the ability to improve multiple aspects of metabolic syndrome, weight, blood pressure, lipids, while maintaining a well-tolerated safety profile, short-term as well as long-term. And based on the findings of SURMOUNT, we believe that tirzapatide represents a unique, successful and effective pharmacological strategy with promising results. With this, I'll stop here. Thank you once again, AMA, for giving me this opportunity. If there are questions, we can definitely address them. Yes, sir. Yes,
Thank you.